everyone. It's so nice to have such a great turnout for today. And our guest speaker is Chris Wheeler, social worker with Community Mental Health, and her topic is anxiety and depression. And we have some fun events coming up. We've got What Your Mama Never Told You, July 25th at the Blue Border Bark Shanty in Port Sanilac. Not the Blue Border Bark Shanty, I made that name up. Blue Border Sports Bar in Port Sanilac. We have Dr. Walker, Brandy Tripikowski, and also Nicole Beagle from CMH. So be sure and take a postcard if you don't have one. Starting every Thursday in August, we're offering a Matter of Balance class in Peck. We've been in almost every town but Peck, so we're going to Peck in August. Brand new is the new 2019-2020 resource directory. They're at the back table. If you haven't gotten one, please take one with you. Great resource of information. Our August Lunch and Learn on August 21st features Dr. Walker, who does a marvelous job on vitamins and supplements. You'll want to hear that. And at the end of this month, we're having the latest on our drug scene, July 29th. So you're welcome to all of them. And Tanya, if you want to wave, you always register with Tanya, and she'll make sure you have a seat and a lunch. And we have a spot right up here for our newcomer. Okay? All right. And with no further ado, Chris.
Thank you. Very nice. Wow, what a nice community. Oh my God, we have so many resources that I didn't even know about. I kind of thought that I was a resource guru, but I guess I'm not. So I'm going to have to spend more time at McKenzie. So as she said, my name is Chris Wheeler. I've worked at Community Mental Health. I'm going to kind of tell you a little bit about my background at Sanilac County Community Mental Health for the last 4 years. Prior to that, I was a supervisor in Saginaw, and for Saginaw Community Mental Health for a private agency. I supervised 400 clients from Community Mental Health, as well as I supervised drug court in Saginaw. And prior to that, I worked at Huron Behavioral Health for 18 years. So my whole career has somehow been linked to community mental health. So right now I have a brand new position, and I'm kind of going to talk to you guys about it a little bit. I think it's just absolutely wonderful. I'm the new jail court liaison for Sanilac County. It's a new position that Sanilac County Community Mental Health decided there was a need for. So I'll kind of talk about what I do, because I think it's relevant to what we're talking about today. So today we're talking about anxiety and depression. Now, I don't know about you guys, but I've had both. I mean, that's what life is, right? We have our ups, we have our downs, but it's how we cope with it. That's the difference. When do we need treatment? When don't we need treatment? You know, I think that's really important. So I'm gonna let you guys eat, and then afterwards, when I get done with my presentation, I'm gonna pass out some facts, okay? I'm sorry I don't have a board, because I was just asked last week to do this. So, and being anxious, I decided this morning to change my presentation to include more stuff. So, and then they called me and said, hey, well, can I videotape? And I said, oh yeah, let's add some more anxiety onto that. So that's everyday anxiety, right? So when we talk about anxiety, I think that we really manifest those things in physical symptoms. It's something that it's tangible. Our heart starts beating faster, our palms sweat. We feel our heart racing. You know, it is very physical, that anxiety that we feel. So it can be described as an abnormal, overwhelming sense of apprehension to almost fear, marked by physical symptoms, which I just talked about, your increased pulse rate, your heart rate, You're doubting that you can complete that task, whatever it is. So it's talking in public, giving a speech at church, writing something, so we feel that anxiety, and we want to come across as we can succeed. So that's normal anxiety. There's three primary causes of anxiety: traumatic events, genetics, and making choices. Of course, there's other factors, but those are the primary ones, okay? So, when a person has anxiety, I think a key is, especially for like the medical staff, there's increased visits to the ER, because those things manifest. We have an idea in our head, well, I should only be anxious for like a day over that. But what if it lasts 2 days? What if it lasts for the whole week? Then you start becoming concerned about your health. So some of the things are pounding heart, you're racing, sweating, feeling jumpy, trembling. Have you ever been so angry or so upset that you're just trembling? I have. Hard time catching your breath, feeling a fullness in your heart and your chest. And that may be perceived as like, am I having a heart attack? We don't know. Feeling dizzy, stomach aches, and having a hard time going to sleep. I know when things are bothering me, that's my first clue. I'm having a hard time going to sleep, because I keep thinking something over and over again. It's like, should I have done this? Should I have done that? So that's more, it's an excessive sense of worrying. Okay? So that anxiety also has levels, which is mild anxiety. Today, me speaking, I feel my heart racing. I'm thinking, are they all looking at me? Of course they are. But mild anxiety is actually pretty motivating. You want to do the best. You need to solve the problem. So you're still really focused. You get lost. You want to find your way to the main road. You ask somebody for directions. You get on the main road. You feel better. Okay? So that anxiety goes away in a situation. Moderate anxiety. So moderate anxiety to me is that you're exclusively focusing on that problem. I can remember one time we were up north and I lost my son in the crowd. And it was like a huge crowd. And I'm like, oh my God. And like nothing was going to stop me until I found that child. So that's kind of moderate anxiety. Like you have a problem and you have to focus and you have to solve that. But then, your symptoms still subside. You want to make sure that they're subsiding, that after the problem's solved, I'm okay now, This is when we start running into problems, when you have severe anxiety. So those anxiety symptoms that I talked about, your heart racing and, your chest pains, and you're feeling sick to your stomach, and you can't concentrate, you can't keep a thought in your head because it's like over here, over there, it just whirls around from one problem to the next problem, or creating more problems. But what if? And so then you go down the what if trail. So that starts to find some impairments. So then you're having a hard time getting out of that anxiety. And if that becomes perpetual, more frequently than not, that's when we have some anxiety problems. And that's when the anxiety is going to start. You may not have an anxiety diagnosis yet, but you're going to start seeing the doctor more. Because you're like, I don't know why I can't calm down. I don't know why my heart's racing. I don't know why I can't concentrate. I can't go to sleep. They're very physical symptoms. So then we start becoming concerned. And then there's the last level of anxiety, panic. I don't know if any of you have ever had a panic attack, But it is very difficult to pull yourself out of, because your thoughts are racing. Your thoughts go from, oh my goodness, to I'm gonna die, I'm having a heart attack, oh my goodness. And it's really difficult to control that thought process because you're not really rational at that point. So this is when we start developing significant problems, when your anxiety is starting to impair your life. It's starting to impair your ability to go to work, socialize, financially, because maybe you're not leaving and you're calling in food all the time. I don't know. There's all different aspects you're not seeing your friends. So this is impairing your life's ability to live a life. So I want you to know, and I'm going to pass out some more stuff, so keep eating. Don't stop eating. I want you guys to multitask. The anxiety disorders are the most common mental illness in the United States. It affects 40 million adults. That's 18% of our population. That's a lot. So, but guess how many people get treatment? Only 36.9%. So out of that 18% of the population, only 36% of those people. So maybe that's like 1 out of 4 are getting treatment for their anxiety disorder. And I think that when I was growing up, I can remember my first job was here in Sand Lake County, and I was the only MI case manager. And so I had 70 clients. Let me tell you about anxiety. I couldn't keep track of them. So, but as time grew, we really only treated the very, very severe individuals. But anxiety can be impacting a life. It really can. It can be immobilizing. You can be stuck to not live your life. So people with anxiety disorder are 3 to 5 times more likely to go to the doctor. So what do we need to do? We need to start educating our primary care doctors about depression. It's easy for individuals to identify the physical symptoms, but let's be open-minded about those things. Could that be depression? I don't know. So, and then 6 times more likely to be hospitalized with other psychiatric illnesses. That's a lot of money in our healthcare system for untreated anxiety. And I think one of the things is, nowadays, we are making strides about our mental health. Like, when I was younger, you just bucked up your shoes, oh, it'll be all right, it's okay. You don't need to go to the doctor. I don't even remember going to the doctor unless I broke a bone, okay? I mean, that was physical. You could see it was broke, so you went to the doctor. Especially in this rural community, I think that that's more so because we didn't have a lot of doctors. I mean, it was like in Cass City, I can remember, that's where I'm from, 2 doctors, Dr. Donahue and Dr. Hall. And Dr. Hall's still my doctor. I mean, that's like, that's all you had. So, and then the people who had those issues were working on the farms and stuff, I seen that everybody had 40 acres, right? 40 acres and 5 cows and, and so if somebody had some problems, we kind of just let them be, they work the farm and stuff like that. So, but there's not those 40 acres anymore. There really isn't. And so now we're starting to see that. People have a lot more anxiety. We're starting to see it in families, and we're starting to talk about it. And that's great, because how else can you educate people except for talking about it? So, one of the problems with treating anxiety is the primary medication for treating anxiety is benzodiazepines, which is Ativan or Xanax. So, which is an addictive medications. So we've all heard about the opiate epidemic. I would say there's also a benzodiazepine epidemic too, because now the doctors are treating that, but they're more reluctant to give those medications. But what happens if you've been taking Ativan for 10 years and your doctor says, hey, I'm not going to give you that script anymore? Oh my gosh, that's panic, Phil, okay? And those medications are getting harder and harder to find. But there are other medications. SSRIs are very effective in treating depression and anxiety. So we're trying to get away from that because maybe they're not worried about you, but maybe your grandson's coming in, taking your pills. That's really an issue. So that's why those medications are being controlled a little bit more. So then we go on to depression. And depression really, if it becomes bad enough, it changes your level in serotonin. And people don't understand that. If you are depressed for a long period of time, maybe someone died in your family, and you can't get over it, and you grieve, and you go into a complicated grief, they call it, and you grieve for 2-3 years. So taking medication increases that serotonin level. I mean, your chemistry in your brain changes. And if it's so bad, you may never be able to produce that serotonin again. Some people can and some people can't. It's all individual. So when we talk about these illnesses, these are serious illnesses that change the way you feel, your health. And I think that's one of the things people are like, oh, you're depressed. Just come on, you can do it, you can do it. I know people that are depressed that can't get out of bed. I know people that are depressed that can't work. And that's so physical, you know? I know people who don't have anything to do with anybody because they're so isolated because they're depressed. And I'm sure we all know somebody in our life who has been depressed, you know? So part of that with the change in the brain chemistry is genetics. If your family has a strong history of depression, you're at higher risk of having depression. A change in hormone levels. We see that like when women are going through menopause. We see that when men have maybe prostate cancer and they have to take estrogen to have that testosterone go down. Certain medical conditions. As you get older, dementia has a strong association with depression. You're starting to lose your independence. Stress, grief, those are all life circumstances, but not one factor contributes to your depression. It's kind of a combination of things. Maybe you're just predisposed to depression. And that one straw, whatever that may be, is what puts you over the edge and you go into a major depression. So it's not always a slow, you know, I feel depressed. It could just be a sudden thing too. You know, you don't know. So it's not uncommon. I think people get hooked, kind of hung up on diagnoses. Is this anxiety? Is this depression? But quite commonly, they're together. It's the most common comorbid diagnosis. And comorbid means more than one. Whether it's a medical diagnosis, whether it's substance abuse, whether it's another mental health diagnosis. So if you're presenting to your doctor one time sad, of course, he's going to probably say, let's do this and this, try some antidepressants. And then the next time, anxious, because you can't control it, they're very linked. They're very linked. Even though they have very different symptoms, it's so common. So just basically understanding treatment is more important than the diagnosis, because the treatment is often the same. Most of the SSRIs, which are the antidepressants, also have components to help control that anxiety too. So, let me flip my page. All right. So some of the symptoms when you're depressed are you're sad, you're tired, you have trouble focusing, you're unhappy, you're angry, you're irritable, you're frustrated, you lost interest, sleep issues, too much, too little, no energy. You crave usually sugary foods because it's bad for your body. So it makes you feel less energetic. A little bit of anxiety, and you isolate. So, there's 3 types of depression. There's chronic depression, and we used to refer to that as dysthymia. And it's a milder depression. It's not a major depression. You just kind of feel sad. You don't want to do anything. You lost interest. You're not, in your quilting class anymore. And that dysthymia can last up to and over 2 years. That's how you know it's chronic. So, but then there's times when you have this dysthymia that you go into a depression, a major depression. And so that's called double depression. Because it's like, how can I have dysthymia and I'm getting treated, but your depression gets worse? And at that point, that's when you go back to the doctor and you say, hey, I'm feeling a little bit more depressed. I'm having no energy. I just don't want to see anybody. And you talk to your doctor about that. So though we have renamed that as persistent depressive disorder. And it's kind of a continuum. You might have dysthymia and then go into a major depression. The treatment is the same. I think that's the thing I want to emphasize to people. So dysthymia affects 1.5% of the population, and only 61% of the people receive treatment. Wow. That's really sad, isn't it, when you think about it? So then the next type is relapsing, remitting depression. So you feel good for 1 month, and you have a lot of energy, and then the next month, next 6 months, maybe not. I have that. I can see that. Seasonal affective disorder. Oh, come that time, that change in that fall ahead. Yeah, pajamas, we ain't going outside in the snow, so I do feel that. I feel that I don't want to do as much, I'm not as energetic. So there are alternatives for that. You can have light therapy. I choose not to treat that because I already know that's coming. Come November and Christmas, after Christmas, it's all downhill until the clock goes back, So, so that's how you don't have enough sunlight. You're not moving around and exercising. You're not going to this because you're like, oh yeah, I'm snowed in. I don't want to put my coat on. I don't want to put my boots on. So you just see the difference. So when it's relapsing, that means that, okay, you're fine, you're on your antidepressant, but then you have a major depressive mood, okay? And that just might be your cycle. I know come November, I'm kind of like snuggled in. I'll go binge watch something on Netflix and I'm all good. Give me my brownies and a cup of coffee, ready to go. So, but depression can become so bad during this time, and I think this is really important, that people can become psychotic. I don't know if you've ever known anybody. So then so that is the severity of how bad depression can get. And how we know that it's depression is that when they're treated, it only lasts temporary. So then they're going to have different diagnoses during that time because somebody's going to be psychotic. Do you guys all know what psychotic is? When people hearing or seeing things, being irrational, believing things that aren't true. So, and then the next and last depression is treatment resistant. Because based on a psychiatrist or your doctor's thoughts, it's kind of trial and error. You know, someone might try you on Lexapro and then they might try Cymbalta, and Cymbalta works great. But the Lexapro didn't. Or maybe they've tried you on 3 or 4 medications and none of them are improving your symptoms. And that's called treatment resistant. So usually I think when I've talked to Dr. Mitchell, usually the trial is 2, and generally after the second try, they're able to hone in, because it's a guessing game, because everybody's body acts differently. There's not a magic pill. You know, we're all going to take Lexapro and feel great. No. So, and men respond differently to antidepressants than females. So men usually have the neurotransmitter, which is Wellbutrin, Cymbalta, Effexor. They respond better to those. We do know that. And women respond better to SSRIs. Okay? So, and if it's so debilitating, sometimes there's excessive. The doctor may recommend ECT, which is electroconvulsive therapy. That means the depression is so debilitating. There's no other medications. So, I think the important thing to take away from this is that anxiety and depression is very treatable. With medications or individual therapy, the results is over 75%. I mean, that's wonderful. So, the more severe your anxiety and depression is, the more symptoms, the more interventions you'll need, of course. You know, if they're mild to moderate, you know, usually CBT and medication works. More severe, they're probably going to be over at community mental health. A general practitioner is going to treat you mild to moderate symptoms. And community mental health is reserved for severe to chronically severe treatment of psychiatric illnesses, because we couldn't treat everybody. I wish we could, but we'd have to build a bigger building and hire, I don't know, a lot more people. But I think that we provide good treatment. So I think that's really important. So I'm going to pass out some facts and statistics. And this is kind of where I'm sorry. Would you like to pass these out for me?
Sure, I certainly
She works with me. I think it's important, and I'm just going to read some statistics, because I think I want you to understand how important it is to get treatment. So, if you are diagnosed with major depression and anxiety, you are 16.2% more likely to have additional problems. So not only does that your mental health affect your physical health, I mean, that's basically what we're saying, right? There's a strong link there. So major depression and a comorbid disorder of anxiety accounts for 57.5% of the people over their lifetime. So you're not going to, it's unlikely that you're going to have just depression and just anxiety. I guess that's what we're coming away with. You may feel both at the same time. So I looked up some information in regards to your primary care doctor. So over half of the outpatient visits are associated with anxiety and depression because you're going in for symptoms. So that's what you're going to present with. I'm feeling tired. You know, is my thyroid working? I'm feeling anxious. Do I need to be on a heart pill? Do I need to be on a blood pressure pill? Patients with major depression and anxiety have more depressive episodes. And one of the things is that those depressive episodes over time get longer and they get more difficult to treat, and then they become persistent without treatment. So I think, it's just important that we know what we can to get treatment for not just you, but for relatives. Education is the key in life, isn't it? So I think when you're looking at some of these statistics, and I didn't talk specifically about the anxiety diagnoses, and I put them in the facts, and the depression, it is staggering to see how many people are diagnosed but then also untreated. Because one of the problems is with anxiety and depression, okay, so you're taking your antidepressant for 2 weeks and man, you're feeling great. You're like, oh, I haven't felt this good in so long. So you take it for another 2 weeks and after a month you're like, yeah, I think it's all good. And so what happens is you have a half-life of that medication. So that half-life lives on 2 to 3 weeks probably. And then something stressful happens, just say on the 6th week. You're feeling the down now. And then this is when the reoccurring depression hits. It's going to be even worse than the initial one. So then you bottom out. You go back to the doctor. And the doctor says, well, let's try on something else. Okay? But you forgot to tell your doctor that you stopped taking that medication because you were feeling good. That's consistently a problem. And I get it. I mean, you're feeling better. Who wants to take medication? But depression, remember, is a change in your serotonin. So if you've had a long-term depression or a severe depression, you just may not be able to produce the level of serotonin anymore that's required for you to feel happiness, to feel a little joy. So then we go into panic disorders. People know people that have a panic. I'm not going there. Nope, not going to happen. You couldn't drag somebody out of the house because I know someone, my aunt, she does not like to cross bridges. Like, I do not know how you travel. Like, she gets all sweaty, upset, finds a different way to go around. Are you kidding me? I can't even understand that. Like, just go over the bridge, I take it she's never been to Mackinac, so. But so those panic disorders usually start to develop when you're pretty young. You can see that. Social anxiety. I hear this a lot. I have social anxiety. Well, only 6.8% of the population does. But really, social anxiety starts when you're a teenager. You start seeing that 13-year-old that's not going out. You see that, they should be hanging out with their friends, and they're not. So you start seeing those symptoms really young. But sadly, 36% of the people with social anxiety disorder wait almost 10 years to get treatment. I don't even know how they got out of their house to get there. I mean, it's like, wow, that's debilitating, isn't it? So not specific of phobias. And that could be, the one that comes to my mind is people who are afraid of germs. But it's to the point where it's impacting their life. They're washing their hands, they're not touching the doorknob, they don't want to go home and they have to clean their house. And so those phobias then turn into obsessive compulsive, don't they? Because those rituals that they're doing not only feed their anxiety, but soothe their anxiety. So that's a problem, isn't it? It's just like biting your nails. You shouldn't bite your nails. And you bite them down eventually till they bleed. That's wrong. It hurts. But you keep doing it because it soothes something. You're anxious. And then once you do something repetitively and you have that quick sense of soothing, then it becomes habitual. And that's when it becomes a problem to break. So only 1% of the population has OCD. So, but ironically, the average age of when those things are starting is at the age of 14. So those individuals who can never do anything right, those individuals that have to erase their homework, and write it just right, and it's never good enough, that's really, we need to monitor that, don't we? Because sometimes good enough is good enough. So post-traumatic stress. Post-traumatic stress is more widely used. We used to reserve that just for veterans. But you know what? There's a lot of trauma out there. Believe you me, there's a lot of trauma out there. I go to the jail and the court every day, and I see it. And so that starts young sometimes. The neglect at home, the sexual abuse, date rape. Things that you talk about but you don't talk about. Because there's something you don't know how to soothe those individuals. So those individuals are more likely to develop an anxiety disorder. So when you're young and your parents were neglectful, you start using substances, don't you? Because you got that anxiety. And this is kind of where I changed my presentation. And then it goes on to talk about major depression. Very closely linked, very similar. But I wanted to talk a little bit about substance abuse. And the reason why is because when we are diagnosing somebody, what came first? Because all of our money is separated at community mental health. It's either a mental health issue or a substance abuse issue, okay? But I just got done telling you, if you had a childhood trauma, you are likely to develop an anxiety disorder. So what do you say to your mom when you're 7 and they're neglectful? Hey, can I get a benzodiazepine? No. So what do? They start drinking. They start smoking pot. So what is really first? Is it the trauma? Is it the substance abuse? I don't know. So at community mental health, and I think most places now, we really try to treat the whole person. You know, it's not just about your substance abuse. It's not just about your mental health. It's you as a person. Let's treat what's going on. It was staggering to see the substance abuse. And actually, this was the first time, I mean, I knew, but I looked up the statistics to find it. So anyone with an anxiety disorder in the 17%, I think that's low. I really do. Based on my 30 years of working, I think it's underreported. Opiate disorders, 12% for men and 21% will have a comorbid diagnosis of anxiety as well as substance abuse. And people say, why opiates? Opiate is a euphoria. Opiates are painkillers, Vicodin, Tramadol, you know, all of those things. And as you get older, everything hurts too, you know. But you take a Vicodin or a Norco, and you kind of get this euphoric thing going on. Yay, it's all right, you know. And you kind of like that, you know. So before you know it, you know, you were taking one Norco, and now you're taking 3. Is it your pain? You know, the pain pills are something that's really touchy, because how do you describe somebody's level of pain? You can't. But also when you do the opiates, it sends a signal to your body because your body wants that opiate. So you may have phantom pain, or your pain may be more because your body wants that opiate. It's extremely addictive. So that is why most doctors, when we're talking about an opiate epidemic, we are talking an opiate epidemic. I was down in Ohio, and I'm driving along, and it says, if you see any drug drivers, please call. And I'm like, oh my God, what is that, you know? And I said to my aunt, I'm like, did that say drug drivers? She said, yeah. So going over, there it goes, right? I couldn't believe it. Ohio is number 1. Michigan is not far behind. So doctors are really, that's why you've seen a change in that. Ongoing doctors, like you're getting your opiates now if it's a pain issue from neurologists or pain clinics. They are dropping for other prescription medications. If you want to smoke medical marijuana, then you ain't taking no opiates. So, you know, they're really cracking down on this because it's become an easy drug for young children to grab. They go to grandma's house, she's got some Norcos. So that's why they're really tightening down on that. Because now we're seeing children, young children, 16, 17. When I was in Saginaw, it was not unusual for kids to be 18 years old, be out of jail, already on their second rehab, and starting on heroin. It's out there. We live a ways away, but don't think it's not in your neighborhoods. It is. It is in your neighborhoods. It's just a little bit better hidden here, okay? So, sorry people. Post-traumatic stress. 2 to 4 times more likely to have a substance abuse diagnosis. As high as 50% of the people. And you know what? I can say, yeah. Most of the people I see in jail, they're right in there. Serious childhood neglect. You know, so it's really sad. So, and you can go on to read. So the least likely person to have substance abuse is OCD. They probably don't want to turn the cap to get the meds up. I don't know. So I'm going to tell you a little bit about my job and why it's important. So I'm the new jail court liaison. So community mental health, along with Judge Ross, Gary Benicki, has decided that we're going to try to treat people versus punishment for people who have mental health issues. So that's what my job is. So I go over and I assess whether the individual wants help, whether the individual is committed to help. You can kind of weed those out real quick. And I try to help them. So then also I monitor them and then report to their probation officers or parole officers. And I got to tell you, we've had great success. I think I'm monitoring about 40 people right now, and I've only had one person go back to jail for one day. And these people that I have, our recidivism rate was at least, I would say the average of twice a year they were in jail. So that tells you how prevalent it is. So we're doing treatment as a community. And Judge Ross and I this morning just talked about substance abuse. A lot of my individuals have substance abuse too. Of course they do. But I treat them the whole. But they start telling their story to me, and it's just really sad. No wonder they were drinking at 13, you know? So my objective here today was to let you know it's okay to go to the doctor and say, you know what, I'm just not feeling myself. Or to have an open conversation with somebody about, hey, are you feeling okay? You know, is there anything I can do? There's kind of some shame that goes along with mental health issues. But as you see, there shouldn't be. It's everyday people. Stress. Life is stressful. Making choices, making money, making house payments, paying your bills, worrying about your grandkids. You know, I mean, it's stressful. And I can understand that. You know, we're not used to this kind of stress. Our body can't keep up with it. The older I get, the less stress I can handle. So that's what I had to say today. Is there any questions? Oh, you guys are talkative. No questions about depression and anxiety? Yes.
Yeah, so you live with a person who you think has depression.
Uh-huh.
How do you convince them to do something?
You know, that, one of my tricks, because over at the jail, they won't talk about depression and anxiety, but let me tell you, they'll talk about their substance abuse over there, because that's acceptable. Okay? So, you know what I do with that? I have these little pamphlets about depression. I just kind of like put them around. God, I just got this today. Just leave it around and let them read that and let that sink in, because part of that is education. You know, I mean, I get it. You have to have a willingness to treat. But maybe part of it is they're stuck on their physical stuff. It's physical. But maybe we need to look beyond that. You know, and part of that is educating them in a nice, subtle way. Because depression is going to become, I'm not depressed. I have pain problems, you know. So, you know, those are the issues. So you just kind of let that information flow out. Find more pamphlets. I had an individual in jail who was schizophrenic, and Dr. Mitchell said, please give him this. And then I started printing off stuff. All he had time to do was read. So eventually he's like, maybe. You know, so just opening that door, having a conversation, talking about your own depression, having a friend talk to him about their depression. You know, I think that's how you start. You gotta start with making it okay. And it gets difficult when you're older. You know, I know my mom. My mom came from, you know, no medications, and you just get out there and do it and stop being lazy and yada, yada, yada. And I'm like, Mom, I'm so overwhelmed. You know, going to school, raising my kids and making a house payment. Blah, 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 blah. No. I mean, that was her attitude, you know. So we're trying to break that. You know, education is the best way. Next time, have them come to a lunch and learn. Oh. I'm sorry. Any more questions?
I do have one, and it's something that I hear out in the public a lot.
Okay.
And whether it's a myth or not, I don't know, but I hear people complain of community mental health is only for people who don't have insurance.
That's not true.
People who have insurance are the ones that are struggling because they can't afford to or can't get into somewhere, and so I hear that a lot in the public.
Community mental health, that is a great question. I'm glad you asked. Okay, community mental health is a government agency, and we are designed only to treat severity of individuals. So now we do a locus score. Regardless if you have insurance or not, everything has to be measured. You know what I mean? To meet a qualification. So if you meet that qualification, that locus score, and I can't remember it, I think it's above 17, which means nothing. You have all these different questions you gotta ask. And the higher you go, you are more likely to have a psychiatric admission, and we are gonna take you on. So it's not really about the insurance. We're only capable of providing services to so many people. Do you know what I'm saying? And, but there are other people that provide services, so we try to utilize them. Go ahead, Louise.
Excuse me, I wanted to springboard off of Wendy's question because I had the resource directory in my hand. So community mental health is listed in here, and their 24/7 phone number is
Yes.
there. So if there's an episode where you're really feeling anxious or very depressed, anybody, 7
Days a week.
24 hours a day can call community mental health. The other options that are identified in this book is we have telepsychiatry available here through McKenzie Health System.
Right.
We have telecounseling also available through our health system, and Lakeshore Counseling, which has offices in Lexington and Sandusky and Bad Axe,
Yeah.
also has a psychiatrist available to them. And if you're having trouble finding a provider, you can also call mental health crisis
Absolutely.
number, and they will help connect you to a provider.
So I understand why, because people don't understand. They don't understand our government agency is set up for the very, very severe. I wish we could treat all of you. I'm honest to God, I do, all of Santa Ana County, because we have the best therapists there are. And I feel that's just my own biasness because they're my colleagues and I work with them every day. But we can't. I mean, we struggle as an agency to balance things every day. So, you know, we try to make those referrals, and anyone, no matter what insurance you have, if you feel like you're having an anxiety attack, you don't know what to do, you can walk into our agency from 8 to 5 and talk to anyone. I don't care what insurance you have. Or you don't know where to go. Walk right in. Talk to the crisis worker. That's important, to know where to get help. Where do I start? Where do I start? And we're a great resource for that. So, any other questions?
Well, let's say thank you very much to Chris. Very important.
Thanks for being such a good audience.